I think we've started to use it, but I think there are some questions. So we obviously have urothelial approved based on extended high quality phase 2 data with overall responses and endpoint, and that's available in the United States, but is not approved elsewhere. So from that perspective, we need some randomized trials to look at that, and we have several that are ongoing. We have one with urothelial compared to chemotherapy of choice in patients that have FGF alterations. At this meeting, we saw the presentation of data from FORT1 with regorafenib, another FGF inhibitor, compared to chemotherapy. This was a phase 2-3 design where there was a requirement for efficacy by overall response to go ahead. In that study, a novel assessment of FGF was undertaken with RNA-scope, mRNA assessment on tissue, and used to select patients. Using that biomarker, there was no difference in overall response between regorafenib, the FGF inhibitor, and chemo. And further assessments were undertaken to look at outcomes. There was also no difference in disease control rate. If we drilled down and looked at DNA alterations by mutation or translocation or fusion, we saw that there was an increased response rate in the FGF treated patients, but lower in chemotherapy. That did not appear to translate into a progression-free survival or overall survival benefit. And so there are questions about whether in this study the biomarkers are imperfect, the drug might have been inferior to some of the others. But we need to look at that with a little bit of circumspection before we get on the FGF bandwagon. And as always, I think we need well-designed randomized studies that are conclusive, and we don't have any yet.